Mode.
Hello and welcome to today's webinar, Hospital Diversion Services, Developing a Peer-Respite Diversion Service in Your Area. I'm Leah Harris with the National Empowerment Center, and I'll be your moderator for today. Before we begin, I wanted to share with you that this is the third in a series of webinars on peer-run crisis alternatives that the National Empowerment Center has organized this year. Please visit our website at www.power2u.org and click on Crisis Alternatives in the left-hand menu bar to access the archives of the other webinars we've hosted on this topic, as well as videos, documents, and a wide range of information on peer-run crisis alternatives. And just a little bit of housekeeping. This webinar will last approximately 60 minutes, including time at the end for Q&A. You are welcome to submit a question at any time using the question or hand raise function if you wish to ask your question verbally. If we do not get to your question today, we will be sure to keep track and get back to you with a response as soon as possible. And this webinar is being recorded. It will be archived on our website, power2u.org. So please do check back in the next few days, and we will have that available for you. And now we are very fortunate to have with us today Steve Miccio, who is the author of the guide that we'll be learning about and discussing today. Steve is the executive director of People Incorporated, a peer-run organization in New York. Steve is considered an expert in peer-operated diversion services and emergency service design. People Incorporated has been delivering diversion services for the past 12 years and advocacy services for over 22 years. Steve, thank you so much for joining us today, and feel free to go ahead.
Well, thanks so much. It's so nice to be here and to be back again. Well, hello, everybody. I'm not used to doing these by myself, but this should be fun. I don't know if people have gotten the manual yet, but you can get it on our website, and you can get it at the National Empowerment Center's website as well. Our website, you can see there on the slide, is projects2empower.org, and you would find it there. So I think I'm just going to give you kind of a brief overview of the manual. And then in addition to that, we do provide some additional training that we can come out, or you can come in and actually work the houses here in New York if that's something that's of interest to folks too. So let's get started. Let's go to the next slide of what's in the name. Now, this is important in asking what's in the name, because a lot of people do call it respite services, or they call them hospital diversion or crisis diversion. But it's really, I call it respite diversion now, because it just makes it easier to explain to people what it is. And later on, when we talk about looking for houses in your community, you'll see why it's probably a better idea to call it a respite service and not a crisis diversion or a hospital diversion service. And we'll talk about that in a little bit. Okay, so the next slide, we'll talk about, are you ready for it? Why would you want to open a diversion service? And just to give you a little history of why we opened our diversion house here at People, it was based on my own personal experience of being hospitalized in a psych hospital, and as well as others that I met as I worked here at People. And that experience was not always the best or healthiest experience for a lot of us. And so my idea was to find something and create something that would be more recovery focused, more compassionate, empathetic to people that were coming in, and would really allow people to think about what it is they're going through and how they could look at things differently. So a lot of, we looked at reducing trauma. It's much more comfortable to come into a nice house and a nice living setting rather than a hospital setting. Looking at crisis as opportunity to grow and learn, to move towards a better path. If you feel less traumatized and you feel more comfortable, you're certainly going to want to, you're going to be more open to new ideas. Promoting a more positive atmosphere and environment in which to heal. Of course, that's I'd rather, again, be in a home than a hospital setting. And then to illustrate that change that changes the paradigm of traditional services can be accomplished with excellent outcomes. What that means is, I mean, we really are trying to change the paradigm in mental health services, locally and statewide and nationally, in looking at crisis differently and not treating it in a reactive mode, more of a proactive or responsive mode with respect to the individual that you're serving. And that's really what we created it for. Now, the interesting thing that's going on too is that managed care is looking at this as a money saver. Local communities are looking at these houses as money savers. And I just want to be clear that that's not why we created the house. We created the house because it works. It helps people look at crisis differently. It helps to break the cycle of going from home to crisis to hospital. And our outcomes now show how well it works. And it really is a good service that has been created. Next slide. So are you ready for it? Once you've answered all your questions as to why you want to open it in your community, you really want to ask the question, are you ready for it? Because as wonderful as it is to design and set up and even open the first couple of days, it's a challenge. It's not, and I'm not going to say it's not easy, because there are days when it is easy, but all kinds of challenges come at you. So you really want to be prepared before you open your house with a mission and a purpose. Why do you exist? Why are you there? Why are you doing this? And again, if it's to break that cycle of home to crisis to hospital, or to even have a house that's maybe what's called a first break house, they call it, or first experience house, so that people don't have to utilize a hospital if they're in a psychiatric or emotional crisis, is a wonderful thing. So you really want to think about what your mission is and what you're trying to do. And then your overall vision, the vision of what that's going to look like, how that service is going to impact your community, how it's going to impact the people that you serve, and what is that vision? What are you trying to do ultimately? Where do you want to get to? And that's what we work on real hard. Is we would like to see, our vision here in New York is to see a house in every county, at least one house in every county throughout the state. And of course, it would be wonderful across the nation as well. You have to build your infrastructure for capacity. You have to understand finances. You have to understand a business model to some extent. It's really important to have that stuff and to understand what it is you're going to need to operate your organization. Do you have the right staff? We'll talk about that in a little bit, and things like that. And then you want your strategic planning. How are you going to go from having no house to having the house and operating it, and what services will be included in that? So that's another major piece. If you're going to go for the 501c3, that's the other thing you need to decide. Are you going to be tied to an organization that's going to do your financials and take care of your personnel and things like that? Or are you going to be your own private entity? And are you going to open a 501c3? And if you do, are you going to have a board of directors? Even if you don't, are you going to have a board of directors? You might want to think of those things as well. How is your structure, your oversight structure, going to exist, and what's that going to look like? The SWOT analysis is the strengths, the weaknesses, the opportunities, and threats. What's nice is that there are houses now all across the nation, and you can use all of us as resources to find out what the strengths of our services are, what the weaknesses have been, what the opportunities and the threats have been, and that can help you build your own SWOT analysis to see what you have and what you don't have and what you need to work on. So what's nice about, again, moving forward is that we're seeing more and more houses open. We even have a new house in Massachusetts opening very soon, and we're very excited for them in the western part of Massachusetts. That'll be opening soon. So as we continue to grow and open these houses, we have a lot more experience in really figuring out what it is we need if we open our own houses going forward. And then you have to figure out your funding needs. And we'll talk a little bit more about that as we go along in the slides as well. So let's go to the next slide. When before you even choose your house, you want to think about the house that you're going to get. Where do you live, first of all? What's the socioeconomic climate? Do a little bit of the background on the demographics of where you are, where you live. Is it in the heart of the city? Is it rural? What kind of house are you going to want? Now, a suggestion, and what I've learned over the years, we're in our 13th year of operating, is you really don't want to get a house that's too large. I think when you can serve 3, 4, maybe 5 people at a time that come to the house, it's a nice number of folks to work with. It's a real nice community to work with as well. And you can absolutely focus on every individual and work with every individual a lot more intensively than you could in a larger congregate care setting. So our houses, we have a 3-bedroom in one county and we have a 4-bedroom in the other county. And they're really the perfect size. They really work well for us. And I think if we went any larger, it would be a bit of a challenge that we'd have to, maybe adjust our staffing patterns or something like that. But you do want to think about what kind of house you want. Do you want it to be a single level? Do you want a ranch? Do you want, what style of house? Is it accessible? There will be accessibility issues that you do want to address. Do you want to lease it or buy it? If you can buy, that's wonderful because you build equity within your service as well, and that builds more credibility for your organization and a better financial stability for your organization. What kind of zoning is in place? We've been very fortunate here in New York because they didn't know what to zone the houses as because they're not licensed and they're not certified in any way, and we've gotten them certified as bed and breakfasts. And I think that's actually a wonderful approach to opening a house, to call it a bed and breakfast, because it's just a much more comfortable title and environment. And as we know, labels do mean things to many of us, and I think it's just a nice way to really cap off what the house is about. So there are things that you just constantly need to consider in your housing and your parking and things like that as you go forward. Next slide. So if you've chosen the kind of house you want, you might want to start to think about laying the groundwork. You want to research the neighborhood or area where the house may be to see what kind of potential pushback there might be. I worked with the folks in Nebraska. There was certainly some pushback there in the beginning. It was actually very interesting. What happened there was pushback. However, they were invited to be part of the planning committee. I think a couple people responded, mostly with letters, but they did respond. And as they got to know the staff of the diversion house there, the Kia house and things, they started to kind of really embrace them. And they became part of the neighborhood association. They joined it. They really became infused in the neighborhood because people understood more clearly as they got to know the people in the neighborhood what the house was about. So it goes both ways, getting to know your neighborhood and your neighborhood getting to know you prior to going in. We had experience in our second house that we opened. We thought everything was going smoothly. We had notified the neighborhood what we were doing and how we were opening the house and things. And they came to the opening, actually, and were quite outraged at the house being there. Of course, the first comments were, sex offenders, and the second comments were, I have children. And what I learned from that is that we really need to do a better job at explaining and illustrating exactly what we're doing with these houses. It's still going to always raise some kind of concern and fear, there's no question. But at least the more information you can provide to folks and what the house and the purpose really is for, the better it's going to be for the community. And like I said before, calling it a crisis diversion, that really provokes fear. And that was our first experience 13 years ago. We were very excited calling it a crisis diversion house because we know it was for the right thing. But that wasn't the right thing for the community. So that was a learning process for us. Create an advisory committee is a real good idea to discuss the service and gain acceptance. And you can invite everybody to that advisory committee, from the police force to the mayor to local politicians, if there's any others, providers, people that receive services are, of course, the most important to be part of that committee, because you really want to design something around individuals that you know you're going to be able to serve in the community. So that's it's a real good idea to have an advisory committee. Also from the advisory committee, if you were going to go for your 501c3, you could also possibly pick out potential board members as well. So it's a good connection in moving forward and opening your service. Join the neighborhood association, like I said, in order to gain acceptance, and that has been something that's been real successful. I know that Georgia went through their issues. They had opened, and then when people started to find out about it, they went through a huge battle in Georgia where that was really threatened, and that was, again, I think a learning experience not only for them but for us too, going forward and opening houses and having, learning better tools, better models on how to open a house and how to really educate the community as to what it is you're doing. So, next slide. Okay, this is important too because when we first opened our service, it was really just that. It was the diversion house, and we opened it just really kind of blindly thinking that everyone's going to come to the house and there wouldn't be any other ancillary services attached to it. However, we learned really quickly that there are services that grow from it, and every house that I've been involved with has experienced this as well. So it's actually a good thing, but it's a good thing, like for all of you to know if you're planning on developing the diversion houses or respites, to know what to expect before you open it. And there are going to be a lot of things that that come up that your committee or you might think of beyond what I've got here and examples that you might want to deliver in your services. But the house naturally became a warm line, a support line for people that were not quite in crisis, but heading towards that, needed somebody to talk to. And this was a really nice service to have because it does operate 24/7. People can call, and that is a diversion. It really helps people to get out whatever it is they're dealing with, to talk about it, maybe get some feedback if they want it. But it's a really good opportunity for folks to share their experiences and not have to go to the hospital to talk to somebody. The in-home peer companion service was something that came out of this because people were calling the house and saying, I really don't want to leave my house. I'm afraid to. Or, they might be dealing with some real serious issues of why they don't want to leave their house. Or they might want to meet you someplace in community. And so that's what we did, is created in-home peer companions, a position or positions where we can make appointments and come out and see you. And again, that's another piece of diversion. So you don't have to actually have the house to do diversion services. And that's the nice thing about this too, is even if you don't have the house, and if you have a little bit of funding, you can start these diversion services before you even open your house. But the in-home peer companion is, we usually keep it to about an hour or as the person needs it, and it's usually not longer than an hour or so that they will want to talk about their issues and learn some new tools. And we'll teach them about the wellness recovery action plans or advanced directives or just basic wellness plans in general on how to maintain your wellness and think of your what we call illness differently. At people, we don't focus on illness. We focus more on wellness for individuals. And that's one thing that the staff can teach other people is, rather than focus on your symptoms all the time and the hardships of your life, let's look at some of those strengths that you have and work from your strengths. And we work very hard with folks on helping to educate them so that they can make better decisions for themselves, which is a really nice thing to see. Social inclusion services, that we call that nights out here. And what we did is we just created nights out. We rented, in addition to our traditional services, we rent large facilities like churches or large meeting halls, and we pick a night out in that community where people can come out from their isolation if they are isolated, and if they've already been introduced to the Rose House, we've already begun a relationship with them. But the whole purpose is not just to get them out of the house. The whole purpose is to get them to be self-determined to want to stay out of their house for their own reasons, for their own interests. And so within the Nights Out service, we provide information and education, of course, on recovery, but we also provide information about what's out there in the community. So we have the chronogram, and we talk about events that are occurring outside of in the community, but we create events within the Nights Out service itself. So there's a games group, there's a sewing group, there's a book club, there's different groups that meet within the building on a Tuesday night out, say. And so as people build relationships on the Nights Out part of it, we tie everything that they're doing within Nights Out into natural supports and community. So if it's the book club, we'll say there's a book club that meets at Barnes & Noble on Wednesday nights. Why don't I see you two are really getting along pretty well? Maybe the two of you would think about doing that. So every activity that we would do in Nights Out, we would tie to a natural support and encourage people to be self-determined enough to take that that step in doing something independently, because we don't want people to come to Nights Out every week and be there every week. We want them to start to live their life. That's what everyone deserves. And this just helps them to kind of understand that they can do that. We meet so many people that do not have permission to recover. And it's weird that I say that, because people actually needed permission to recover, to know that they could think beyond symptoms, beyond the hardships that they deal with every day. And as they do that, they become stronger. Their recovery gets stronger, and their crisis experience dissipates, which is a wonderful thing that we've seen over the years in doing this. So the social inclusion is also a diversion. And again, you don't have to have the house to do that, but it helps, because that's where you start to build a relationship at the house, and then it grows from there. So it's a nice thing to have. And then there are natural support services. When people come to the house, they want to know what else is going on out there, such as Reiki or natural healing methods, or natural supplements and things like that. So we provide a lot of that information in the house in the form of documentation, internet, and personal experience, from the staff that work there. Just so everyone's clear, we are completely peer-run. Everyone that works at People and works at the Rose Houses has the lived experience. There is no clinical component to it, just so people understand that as well. If we do need clinical services, we have partnered with our community partners, which also becomes part of the service. They'll come, the mobile team will come actually to the house if people feel they need it. We never decide if people need it or not. People that stay at the house decide if they need it. So that's another service that comes into the house, and there is a clinical component to that, but it's not ours. It's tied to natural supports in the community. And if people feel that the service that they're getting at the Rose House needs to be more intense, they might think about having a team come in, talking to them, and then maybe figuring out where they need to go from there. I can tell you that in 13 years, that's happened very rarely. Most of the people that come to the house, I think in the 13 years, we've had 13 emergency service vehicles at the house, and only 2 of those have been psychiatric. The rest have been for medical reasons. So it really does speak to people being self-determined to look at crisis differently and to really work on their own recovery, which is a real nice component of the house. Okay, next we get into the staffing. So you want to decide the type of staff you want in your house. And I'll admit, when I first started running People Incorporated here in New York, we hired pretty much everybody that had a lived experience. And the characteristics were, well, if you had the lived experience, you can be a peer advocate and you can come work for us. As we started to really start to measure our outcomes and to work more intensively on wellness and recovery, we noticed that there had to be other skills involved in people working for us. And then I stepped back at that point and I said, well, who do I think I am, just, kind of bringing people in here? They have to have some kind of characteristics that we need that are going to support them, and so that they're successful in their job, and so that they can support the people that we serve as well. So we started to put in some characteristics in our organization. There's more than that I've listed here, but people do have to have the lived experience. Employment experience is a plus. It really helps. We've had people that have come to work for us and still do work for us that had no employment experience. But the intensity of working in a diversion house, you really, really should have some kind of work experience, just to understand that whole the employment norms of work itself. And I'll get to the intensity of the organization or of the service as well in a minute. Compassion driven is a must. We do some role play in our interviews when people come in to see where their compassion, where their empathy lies, where their listening skills lie. I can't tell you how important listening skills are. Staff really need to be excellent listeners. And they have to understand that there are many different listening styles. So they do go through it. We have a whole additional training that we do where we do listening styles, and people learn those different listening styles so that they can be more effective with the people that we serve, and so that the people we serve know that they're being heard. If the people have special talents, the houses are filled with music instruments and art equipment and craft equipment, anything that might distract someone from their initial symptoms or crises. They can focus on their talents. And so if we have talented staff, that really lends to enhancing and enriching the environment of the house. Resiliency and attitude. I think the strongest and most amazing people that I've ever met are in the mental health world, and they're the people that have lived it, and they truly are a strength. And having staff that have that strength too and resiliency really helps the service to improve. So it's a real bonus. And then level of education is important. It's becoming more important because of what's happening in our country. And in New York right now, we're moving into this health home environment, which is a culmination of providing, through Medicaid, getting services for mental health, physical health, and substance use. They're looking more at the outcomes of the peer-run organizations and the traditional organizations. And so having a good level of education or understanding of how to do documentation and paperwork and things like that is absolutely a plus. So you really want to think about that when you're hiring your staff and bringing them in. Next slide. I'm going to go to core values now. Many organizations create core values. You can go to the top organizations in your area, whether they're mental health or behavioral health or technology or whatever. Many places put their core values out on their walls and talk about what they are. And in many organizations, they value recovery, they value hope, they value resiliency, they value all these different things. But what does that really mean? So when you're developing your house and you're developing your service, you want to ask yourself, how do people know? How does somebody observe my core values in my organization? How do they know that we're empathetic and that we're compassionate and that we are focused on the single most factor of a better quality of life, which we call recovery? And you want to create core values that you can actually put behaviors behind. And once you create those actionable and observable behaviors in your organization, that's the magic. That's the thing that's really going to make this work, because now every staff person in your organization understands the core values and behaves according to those core values. And that's what's going to make your service successful. So we strongly recommend, and again, that's a training that we also do here on helping design and deliver those core values within your organization. So you have your core values. Let's go to the next slide. And the tough thing that you got to start working on is your budget. What's nice is that what I put in the manual is I did put a sample budget in there so that people have an idea of what a basic simple budget is. But if you're, I think I put on here, if you're living in Topeka and you're opening a house, it's going to be a very different budget than New York City. In New York City, it's going to run between $750,000 to maybe $850,000 to run it well. In other parts of our country, it might only cost $200,000 or $250,000 or $400,000. It's going to really be dependent on the economic status of your community, and then also how you want to staff it is going to be important too, because we right now only have one staff on two staff are on during the day between 8 and 5. Between 3 and 11, there's really only one staff. Between 11 and 7, there's only one staff. And that works really well for us. It hasn't been an issue. If it becomes an issue, we've got some buffers within our budget that if I need to put additional staff into the house because it's just busy, maybe the warm line's too busy, or you have 4 people in the house and you're working hard with each individual, I'll always put additional staff on. So we have that flexibility. So when you're doing your budget, you want to think about your flexibility in staffing and how you want that to look and how you want that to run. Again, budgets can be tricky, but that's something you can also use us. A lot of us that have open houses, you can use us as resources in those areas as well. So, next slide. Okay, this gets to the real heart of the operations of opening a house. We noticed over the 13 years, people always ask what makes it work. And it's really the philosophy of recovery, the philosophy of people doing better. We don't define recovery. We never will. We never, it's not our place to do that. But people will define their own recovery for the most part. And to make it simple, it's just people doing better for themselves, living a more empowered, independent, and self-determined life. And that's the path to recovery. Our philosophy is 100% around recovery. Our mantra is hope greets you at the door and recovery is the expectation within our organization. And it really is. It's really something we believe in. And so that philosophy has to be infused into your service. And that's the probably single most important factor in your service is your philosophy. Next, you have to have a good environment. I mean, you want to have a real healthy environment that is welcoming, that is comfortable, that feels safe. You don't ever want anyone to feel unsafe in your environment. So environment, again, is key. If you've been to any of the houses across the nation, I think I've been to quite a few of them, and they are all very comfortable, and they make it very comfortable. What's nice is that the environment also becomes the ownership of the guest. And that's one thing that we've really liked seeing over the years is that when people come to the house, they begin to own the house. Even if they're only there from 1 to 5 days, they own it. And they start cleaning up, or they start gardening, or they start doing something around the house that's going to make it even more beautiful or more comfortable for people. They provide us with suggestions on environmental changes that might be more conducive to their own recovery. And that's something you want. You want people to come in and own the house or own the service because it really is about them and finding their path towards recovery and really, thinking real clearly about crisis and how they don't really have to react the way they used to in crisis. The other nice thing about this is we'll move to engagement. As we engage, we build relationships. So when people come to the house, not only are they engaged really nicely in the house, when they leave the house, that engagement continues. They check in with us. They might ask us, can you give me a call in 2 weeks? And we do that. They come to our events. We start to build a relationship with folks. And again, that's real important because that, again, builds that ownership and it provides a path for people to be self-determined in moving forward in their recovery and in their life. But these are the 3 just absolute main components that are going to make the service work. There's ancillary components that I'm sure you'll find will come up and you'll want to develop within your structure. But this really is what makes it work. Also with engagement, it's how you greet your guests when they come to the house. We have a whole script that we use, a very sincere script that says, welcome to the house. We're really glad you're here. Let me tell you what you're about to go through. But before I do that, I want you to go and I'm going to show you the rooms and pick your bedroom. Once you pick your bedroom out, come on down, and I'm going to tell you everything that we're going to do here while you're staying here at the house. And again, we're so happy to have you here. And then folks will go into the room and they'll settle in, they'll put their stuff away. They'll come back down, and it's not like a whole intake. We don't even call it an intake process. It's a registration. Because if you come into a bed and breakfast, you register for a bed and breakfast visit, right? So that's what we do is we go through the registration while explaining to people exactly what the purpose of the house is, that we want them to pick a goal while they're there as to what they want to get out of the house. We provide people with structure that they choose. We don't choose it for them. They get a menu, and it actually looks like a restaurant menu, and we call it the menu of services. And they get to pick from that menu what they want to do. And it could be a 12-step group. It could be going to the park. It could be going for a walk. It could be playing the music. It could be learning more about self-help and wellness and recovery. There's just a whole litany of things in the menu of services that people can choose from. And I will explain, too, that when you start to engage people in this way, it's very different for them because they are used to being told what to do, when to do it, when to eat, what to eat. Everything is kind of prescribed to them. And this really embraces folks that come to the house that says you're important, and you're so important that we're going to let you design your own structure while you're here. That in itself is a paradigm shift for a lot of folks. It's not easy to do because they've been, again, living that life of being told what to do all the time. And we found that it may take sometimes 2 or 3 stays before people really start to embrace their self-determination and really start to embrace recovery in a different way. And that's when you know the house is working, when you start to see those changes in people and they're coming in and they're really working on these wellness goals for themselves and not trying to impress anyone else with them or not trying to be, as they say in the traditional field, compliant or the good patient. We have no patients in our organization. We have people that come and use our services, and we have guests that come to use our services. And that's our attitude towards it, and I think that really helps in really promoting more of a wellness environment for folks to come to and a very respectful environment for people to come to. So engagement is absolutely key. It's how we speak to one another, how we listen to one another, and how we respect one another. And once you start to build that level of trust, you learn more from your guests, they learn more from you, and from that come the solutions of looking at crisis differently. So it really works out for so many folks over the years. Okay, next slide. And I think we've come to the question part. Again, that's a brief overview of the manual. The manual goes into a lot more detail. It has some paperwork in there for you to look at, documentation and things like that you can look at, how to plan your goals and how to, really how to operate the house in more of a general way, and it gets you started in really thinking about where you want to go in your service. So we have some time left, and I thought that I wanted to leave a lot of time for questions because we do get a lot of questions when we are presenting the diversion services from folks.
Yeah, and Steve, thank you. That was so informative and just very, very inspiring. I want to thank you again for that presentation, and do want to reiterate, because a few people did ask where can they find the manual, and it can be found at projects2empower.org. It's available for free download, as well as the NEC website at www.power2.org in our crisis alternatives section. So we'll go ahead now, as Steve said, and open up the floor for Q&A. We'll do our best to get to as many questions as we can in the remaining time. And again, if we do not get to your question, we will be sure to make a note of it and respond to you in a timely manner. So, Steve, we have lots of great questions coming in here, and just keep them coming to everybody who's still on the webinar. The first one that I noticed was, what has your experience been, if any, with opening a house as part of a state-run facility?
Well, we're not part of a state-run facility. There really hasn't been any experience we're actually there is a state-run facility that is looking to open a house. So that's uncharted waters for us right now. So I don't have a clear answer for that yet.
Thank you. We have another question about, does it make sense to open a space as opposed to a house on a part-time basis, or do you need to, have a house and be open 24/7 to be effective?
Well, we actually when we first opened our Putnam Rose house, it was only part-time, and what we found is that it wasn't very busy at all. It was very hard to get people there because we were only open from Thursday to Monday, and as you know, people can't plan their crises. So that was a challenge for us until we got the full funding. We recently got the full funding, and we're 24/7. You don't have to have a house to do diversion services, but if you're going to do a diversion service where people stay over, it really should be 24/7. That is going to be the most effective.
Great, thank you. We have another question. What is your average length of stay, and they say the rate of high use, or people using the respite repeatedly?
Well, the average length of stay is it's actually 4.7 days. I don't know how we do research, and so that's what it came out to. So it's really 5 days. It's 5 nights that people really stay. And the people not it's hard to quantify how many people come back to the house because over the years people use it. But there's a small handful of folks, and I would say there's probably maybe 12 that I can think of right now over the past 2 years that will use the house repeatedly. And so our question became, are they just coming to hang out, or are they really getting something out of the house? So we started asking those questions. And as we were asking those questions, we were figuring out that they were getting something out of it. So we designed and redesigned the paperwork to make sure that as people come back to the house, that they're continuing along their path of recovery. It doesn't have to be a linear fashion, but they are at least continuing on their path of recovery. And it really it helped us because at one point we thought that maybe people were just kind of just coming to hang out.
Okay, so our next question is somebody saying, I'm interested in opening a house of sorts for youths to divert from hospitalization and offer accommodations to family of that youth. Do you know of any programs or have any suggestions for such a program?
That's a very interesting question because that's one of our next projects. We are doing the same thing. We're calling them suites, where families can come with their kids and learn about, first of all, how as a family how to cope, and teach the child as well how to cope and look at crisis differently. That's something that's pretty new. It's not really out there that we've seen yet, and so I think we're on the same page here. That's a pretty neat. It's a great idea, I think. So maybe as we go along, we could stay in touch, whoever that person is, and progress together.
Yeah, absolutely, and I can connect you two up for sure.
Great.
And our next question is, what are the key design elements that should be included in a house?
If that means like for the house itself, I think the accessibility is important, that it's accessible to everybody. The design elements is having more than one bathroom always helps. And we do in both houses, we have 2 bathrooms, and something simple like that, but it really can help. The layout of the house can be important too. Do you have a general meeting area, which is usually the living room? The dining room becomes an important place too, because people they sit down and have family style dinners together, because we don't provide the food, we don't do the cooking. All the guests do their own food preparation and things like that. So that becomes more of a family environment. So a good dining room, things like that are important. It depends on where you are too. Is your parking. is important, maybe, or your accessibility to where you are located in your town or city is another design um, idea that you want to keep in mind. So yeah, but pretty much just having basically a very comfortable environment for people to come to is the most important thing.
That's great. Thank you. There are a few questions about Medicaid. Is this service reimbursed by Medicaid? How is it paid for by guests? And again, if a health home is involved, does a respite home bill Medicaid?
Yeah, well, right now it is not Medicaid. It is deficit funded. We get a couple different pots of money, actually. We get money from the New York State Office of Mental Health, but we also get money from the county itself, who saw the value of the house and are providing deficit funding, annualized funding for the houses. However, managed care is extremely interested in the houses, and I think are willing to fund the houses. The thing I'd want to be careful of is that if you had an organization, a managed care organization, come in and say to you that they will fund the house, um, our our values are that everyone should have access to that house. The managed care company might think differently, and they might say, well, we're only going to allow our customers to come and use the house. And to me, that's not community. I would hope that there'd be a way to figure that out and get around that. But right now, we're fortunate that we aren't Medicaid funded or have to worry about that. And the stays are free. Everyone comes to the house and can stay for free. Now, if you do live out of county and we have a bed open, and we've had people come from out of counties, there is a private pay fee that we would have to ask for because we can't use local dollars um, to to stay at the house.
We have a question about somebody's asking about people who have addiction issues in addition to some kind of emotional distress or crisis. Are those people eligible, and how do you cope with the substance use issues at the house?
Well, it's we deal with a lot of issues in the house, and I would say about 90% of the people that come to the house have addiction issues. And what's neat about it is that when they come to the house, they respect the house because we ask folks when they come to sign a guest agreement, and the guest agreement really is about respecting the house. So we've really not had issues of addiction. I will mention that folks do come in that have um, um, self-harm experience and have done some self-harm in the house. And again, we don't react. We just tell people if you can stay within the guidelines of the guest agreement, you can stay here. So we find that a lot of those issues are addressed right up front, and that people do respect the house enough to really stay within the guest agreement, which is nice.
Thank you. We have a few questions actually on insurance. One of them saying, what type of liability insurance do you need for a respite care crisis diversion home, and how much does it cost?
Yeah, we don't need no stinking insurance. No, actually, you do have to be covered. We have general liability on the house. It does run. We have liability on all our services, so it's hard to really pull out. But I think the cost for liability at the house is under $2,000 a year. Um, so it's not unreasonable, and it really does provide the peace of mind of knowing that the staff and the people, the guests, and the house itself are all covered. So that is important.
We have a question here about either is there an example of the menu of services that you talked about, or could you kind of give some of those examples?
The examples are in the manual. I think the actual menu, let me just see real quick here. I'm looking at it. Yeah, we did put the menu, a sample of menu of services. So we have the starters, we have the main courses, and this, we have art expressions, resources and education around wellness and recovery. We have social events that are happening in community. We have recreation, which can be sports or healthy, refreshing for mind and body, those kinds of things. Peer support, wellness recovery action plan, education, and putting that together. We do advance directives here in New York because they are legal documents. So you can actually start your advance directive, which is a healthcare proxy, a psychiatric healthcare proxy. So just a whole host of services. And as new guests come in and have different ideas, we can add to that menu as well. So there's a lot of room for growth.
Um, let's see. One, and we have a couple questions about the listening, the sort of the training on listening styles. Is there a curriculum? How do you sort of train the staff on that?
Yeah, we created our own curriculum based on all of the different listening styles, language styles that are out there, and it's in our we have a training manual as well, and that's proprietary. That's where we do our immersion training here in New York, and we do come out and do the training as well. But what we like about bringing people to New York is that you get 3 days of classroom training on how to run the house and operate it, and then you get 2 days of actually working in the houses. Um, but the listening skills is constant throughout the training on how we listen, and we role play. We do a lot of role play around those listening skills to understand all the different styles, language styles, and what works and what doesn't. And then we do a large piece on motivational interviewing because we do use a lot of motivational interviewing in the house too. It's our question usually to many folks is, how's that working for you? Because most people have the answers within them. They just haven't really been asked the right questions to really address those answers that they have. So.
Great, thank you. There's a question here about medications. Are people required to take medications when they stay at the house? What is your policy around that?
If you come into the house and you do take medications, you get a lockbox in your room. You get the key to the lockbox. That's yours while you stay there. We don't administer any medication. We don't promote or refute medication. It's whatever the person is comfortable with. We do have a lot of education around medication so that people understand and can make better choices around the medication they use, because we do know from many studies that the medication can be devastating to the central nervous system and to the body and the organs and all that. So we do provide a lot of information around education. And interestingly enough, most people that come to the house, when you're sitting in the living room and you're just chatting, medication comes up probably 100% of the time, because it is such a big part of people's lives. And we try to help people understand that it doesn't have to be, if they're educated properly in medication management or medication itself.
Thank you. That's great. We have a question here about how do people continue their recovery after staying at the house? And you had talked about the natural service and the natural supports that you try to connect people with. What do you sort of leave people with as they're, moving on back into their
Well,
regular lives?
yeah, the nice thing about this is that our organization has grown and built partnerships with other organizations, but we actually opened a recovery center as well. Our recovery center is not a place. It's without walls. And these are mobile peers that work in the community to do a lot of education and continued education and engagement and linking people to community services that are natural supports or are ways that they can choose in their path of recovery. We hold a lot of groups, and we don't hold groups to hold groups. These groups have meaning to them, and because they're designed by the people we serve. And in these groups, we build that camaraderie and that lived experience, that mutuality continues once they've stayed at the house. What we found in the research from staying at the house that we didn't expect was that people's social lives improved once they stayed at the diversion house, because they started to reach out and use the other services that we provide and that some of our other partners provide. And so their social lives have improved and their whole recovery outcomes have improved as well. So everything, when you come into the service, it's not just you stay at the house and you go, we'll see you. We stay connected as long as that individual wants to stay connected. We don't force that on anybody. It's everyone's choice.
Great. Thank you so much. We have a question about if there are folks who want to try to get buy-in from their county or state. Do you have some kind of a PowerPoint or presentation, something that you've developed that has some of the important statistics, um, that
Yes,
kind of thing?
yes, I do.
Oh, great.
Yeah, I do, and anyone that's trying to start this for their state, their community, or whatever, what I've been telling people and what's been successful for me, because we have houses in Europe as well now, and these houses just keep coming. Um, have it have bring them to us is probably the best way to get funders to start to buy into this, and let them see the houses actually in operation, and meet with our staff and meet with me and talk about the successes, the challenges, things like that. I always tell people to bring your funders if you're going to come visit, because that's what has worked for most people that have opened houses.
Thank you. So we have a question here. What is the maximum number of days a guest can stay, and how is it decided when it's time for the guest to return home?
Well, they can stay a maximum of 5. However, we have gone over that. We've had people stay there for 7, 10 days at times, because they have been making good progress, but they're not quite ready, and they've been able to kind of state their case as to why they think they need to stay and what's going on with them. And if we have the availability, we certainly can be open to that. Well, I'm sorry, the other part of the question was?
Um, I think. Let me see. Sorry.
Maximum
Yeah.
stay.
When or basically, what's the maximum number of days a guest can stay, and how is it decided when it's time for the guest to return home?
Oh, the guest really decides. I mean, if we were going through their goal and sitting with them and saying, "Hey, look, I see you really attained this. How you feeling?" The guest is the one that really decides it's time to go within those 5 days.
Let's see. All right. Well, we just have about 3 minutes left, and we will do our best to get to the remaining questions here. Let's see. We have a question about, do you know of any kind of respite models in Canada?
No, actually, not in Canada. They've been in touch with us though, from Ontario, I believe, and I think Quebec. But I don't know that they have any models that I've heard of yet.
Another question about, are you aware of other ways that programs have been zoned or licensed in addition to bed and breakfasts?
Yeah, the one in Nebraska was zoned as a congregate care. I think I would have to, you'd have to actually contact the folks in Georgia, but I know they're registered differently as well. Um, in Europe, they are licensed under the Mental Health Authority out there, so that's how they're registered. Um, but it's so new. There's no clear cut way of doing it, or how it's being it's not being standardized at this point, which is I think a plus for all of us at this point.
Sure. There's a question about, what were the lessons learned or the main challenges in getting buy-in from the public mental health system in your state?
Boy, that was an interesting process, because they actually didn't really understand what they were approving when we first opened and got the buy-in. They thought it was more of a crisis center that had a clinical component to it, but they quickly learned that it wasn't. It was completely pure run. However, I already had built a pretty decent relationship with the state office folks, and so there was a bit of trust there in doing this and moving forward. And so it actually wasn't difficult here in New York to do it. And plus, there was some older models that had opened over the years, so they were somewhat familiar with the idea.
Got it. All right. Well, on a sort of more fun note here, there's a question about food. Um,
Yes.
you don't prepare food, but how is food handled at the house?
Well, people bring their own food. We used to actually supply the food, and what that did is that ate up the entire budget. It was very expensive to do. When we opened the house in Nebraska, we decided let's not even start there. Let's start with people bringing their own food to the house. So that's what we do now, and so everyone brings their own meals or whatever for their 5 day stay to the house, and then they what's neat is that they end up cooking family style most of the time. Everyone shares their food. We do have dry goods, and we are working with a local food shelter now that delivers some fresh fruits and vegetables to us now, which is real nice. But there's no cost to us, which is beautiful. But when we do have folks that come in that are just simply too poor to have anything, we will provide food for them. So nobody goes hungry.
Well, that went by really quickly. Unfortunately, we are at 2 o'clock. And again, for those of you whose question we did not get to, we will get back to you. And thank you so much for your wonderful, thoughtful questions and participation, and most especially to Steve for a wonderful presentation, and just for all the tremendous work that you've done, Steve, to really spearhead the growth of these peer respites across the country. And
Well,
we
thank
do
you.
hope that
Thank
that vision of having them in every county and every state, we really hope that we can see that flourish and grow. So
that would be
please,
wonderful.
yeah, exactly. Please stay in touch. And again, we will have this webinar archived on our website within the next few days. And please do spread it far and wide. And thank you so much again, and have a great day. Bye bye.
All right. Thank you, everybody. Take care.